Welcome to the mini lecture on facilitating shared decision-making. My name is Michelle Weckman, and I'm a physician at the University of Iowa with expertise in family medicine, psychiatry, and hospice and palliative medicine. This short lecture will review some of the legal definitions and the concept of decision-making which is shared between the patient, family, and healthcare provider. It will also provide you with tips to improve communication with physicians. Talking about goals for the medical care of your loved one is critical if you want them to receive the best possible care. This can be difficult because goals may change over time, and someone with dementia may be unable to participate in the discussion. Talking about goals also takes time. You may need to schedule a separate appointment to have this conversation with your doctor. Still, it is important that the healthcare team caring for your loved one with dementia understands what he or she was like before the dementia started. Your loved one will get more personalized care when the healthcare providers know about things such as hobbies, life goals, style of interacting, and previous health decisions. The more information that you can provide to the nursing home staff and physicians about your loved one's previous choices, the better the chances that future treatment is in line with what he or she would want. As you talk with the doctor, she or he will be evaluating what you understand about possible treatment. The doctor will want to know if you are able to give informed consent. A person can give informed consent if he or she is able to understand the medical issues, treatment options, and consequences of choosing a specific treatment. Informed consent also requires the ability to communicate a decision which does not change over time. This does not mean that you can't change your mind, but if you do, you should be prepared to offer a logical reason as to why you did. When possible, physicians try to allow patients to make their own decisions, even patients with dementia. Sometimes a person is able to make one type of decision, but not another. For example, someone with mild dementia may be able to understand that she has a bladder infection and can decide to take antibiotics. But she might not be able to understand why she needs to be placed in a nursing home. She might believe that she is still safe to remain at home despite evidence that she can no longer care for herself. In that case, the family would be asked to make the decision for her. As dementia worsens, the ability to make decisions about care decreases. When a person with dementia is no longer able to give informed consent about treatment, we ask someone else to make these decisions. This person is called a surrogate decision maker. Most surrogate decision makers are close family, but any qualified individual of the patient's choice can serve in this role. For example, someone who is married may request that a friend make medical decisions, even though their spouse is capable of making decisions. Your physician cannot be named as your surrogate decision maker. A surrogate decision maker is asked to make the decisions the patient would have made if able to make decisions. The surrogate decision maker should not be making decisions based on what they think is best for the patient. If someone has dementia, which has progressed to the point that she is unable to make decisions, her surrogate decision maker will be asked to make decisions for her. For example, if she were to develop pneumonia, we would ask her surrogate decision maker what her previous goals were. The surrogate decision maker might say that the patient saw her parents in a nursing home and never wanted to go into one herself, unless it would help her family. The surrogate decision maker might add that the patient adored her children and said more than once that as long as she could recognize her husband and her children, that her life was worth living. The surrogate decision maker then might add that the patient didn't like taking medication, but was always willing to see the doctor and take medications for treatable conditions such as infections. Based on this information, the decision is made that the patient would have wanted treatment for her pneumonia since she was still able to enjoy visits from her family. Physicians are legally required to explain to you what they think is wrong, suggest tests and treatments, and make sure that you understand what was said. A physician is not allowed to hide information because she or he thinks it will upset you. That being said, you also have the right to tell a physician if you do not want to receive information. For example, a husband whose wife has dementia may prefer to have all of her medical issues discussed with his son and not directly with him. The physician should honor the husband's request and only talk with the son, even if the husband is the legal surrogate decision maker. The process I've been explaining is called shared decision making. It is a joint decision made by the healthcare provider and the patient's surrogate decision-making. In shared decision-making, the doctor and surrogate decision-maker review both the medical information as well as the characteristics and values of the patient to decide what the patient would want to do. Shared decision-making has been shown to increase satisfaction with medical care and to help patients receive the care they want. Not all healthcare providers use a shared decision-making process. You can encourage shared decision-making by talking about what is important when you make decisions. In true shared decision-making, you are in control and should be given time to express your feelings, thoughts, and concerns. After you have had these conversations, the physician will better understand your views and can develop plans based on your wishes. In fact, you have the right to ask the physician to make a recommendation based on what you said was important to you. You also have the right to ask as many questions as you need to understand all of the medical facts and treatment options. You should also be sure to ask what impact the decision will have on the possible outcome. For example, suppose your mother has told you that her life is only worth living if she is able to remember and interact with her family and friends. Now, her dementia has worsened to the point that she rarely recognizes family and often chooses not to interact with them when they do visit. You are concerned because she has been losing weight and has complained of stomach pain. The physician mentions that he felt a mass in her stomach and is concerned that she might have cancer. He says he is unable to tell for sure without transferring her to the hospital and doing tests, which could be painful. You know that your mom hated going to the hospital and had avoided the doctor her whole life. You ask the physician what would happen if you chose not to send your mom to the hospital for tests. The physician says that if your mom has cancer, that she would die. You talk about your mom's wishes and previous choices with the physician. Based on this, he recommends that you do not send her to the hospital for more tests, and that instead you enroll her in hospice and focus on comfort in order to make the rest of your mom's life as enjoyable as possible. Shared decision-making can help you to make the decision that your loved one would have made if able. If you decide that you want to share in the medical decision-making process with your loved one's healthcare providers, it can be helpful to remember the following points. You have the right to talk about your hopes, wishes, and goals. You have the right to ask that you are given the ability to share in the decision-making process, and you have the right to have all your questions answered adequately. As we care for an individual with dementia, there will be occasions when shared decision-making is needed. How should we treat this infection? Should we send the person to the hospital? Is medication needed to manage problem behaviors? We will use the example of starting a medication to manage problem behaviors to show how shared decision-making works. Persons with dementia may start to have dangerous and distressing behaviors as their condition worsens. We use medications, known as antipsychotics, to manage these behaviors. We have designed a fact sheet about the use of antipsychotics in patients with dementia to help you understand this type of medication. The fact sheet explains when antipsychotics should be used and how they work. Antipsychotics do not help to improve all the problem behaviors that a patient with dementia may have. The Antipsychotic Prescribing Guide and Family Handout lists the behaviors that antipsychotics can help. It is really a short list compared to all the behaviors that can occur. As you see on the prescribing guide, behaviors which do not cause extreme distress to the patient and are not dangerous to the patient or others are not appropriate reasons to start antipsychotics. Antipsychotic medication should only be given when a dementia patient has aggressive behavior, such as hitting or biting, or is confused about reality and is seeing or hearing things that are not there. When you sit down to have a discussion about starting an antipsychotic, plan to discuss your goals with the physician. Let them know what you hope the antipsychotic will do for your loved one. Sometimes our goals are unrealistic, and the physician can let you know what to expect if an antipsychotic is started. It is also important to share personal details about your loved one, their likes and dislikes, and what you think might be leading to the problem behaviors. This information can help the healthcare team come up with ideas to manage a behavior without the use of drugs. For you to make an informed decision, You need to know the benefits and risks of antipsychotics. As we mentioned before, these medications can help decrease aggressive behavior and keep the patient and those around them safe. They can also decrease troubling thoughts and may help if your loved one is hearing or seeing things that aren't real. The physician should also talk about the risks and side effects of the antipsychotic. A list of the side effects can be seen on the antipsychotic teaching sheet. Antipsychotics can have serious side effects. Fortunately, they are very rare. Both the serious and the common side effects of antipsychotics are detailed on the antipsychotic teaching sheet. Some side effects are seen with some antipsychotics and not with others. Your physician will be able to tell you which side effects to watch for based on the medication he or she recommends. It is believed that antipsychotics can increase the risk of death slightly. For every 100 people with dementia who take an antipsychotic, one of them may die sooner because of the medication. There is no way to tell who might have this side effect. Antipsychotics may also increase the risk of stroke. For every 100 people with dementia who take an antipsychotic, one of them may have a stroke because of the medication. In some people, antipsychotics can cause tremors or shaking, or may cause a person to be restless and try to move around a lot. The chance of this happening is different for each antipsychotic. The physician can tell you if he or she thinks this is a side effect you will need to watch for. Antipsychotics can cause other side effects which are detailed on the fact sheet. The back of the fact sheet has a chart of possible side effects and space to document if they are occurring so that you can discuss any side effects which develop with your physician. The decision to start an antipsychotic can be difficult. Shared decision-making can make the process easier. You need to have the discussion with the physician about your reasons for choosing to use or not use an antipsychotic. The physician will share with you what the choice will mean to your loved one's care. Working together, you can be confident that your choice will honor your loved one's goals and wishes. The antipsychotic fact sheet has a section on how to decide if an antipsychotic is the right choice for your loved one. It explains what a physician will do before starting an antipsychotic. It is particularly important that the physician look for the cause of troublesome behaviors. Often these can be treated without using an antipsychotic. When a cause cannot be found or does not respond to simple measures, medication may be needed. When considering the risks and benefits of starting a medication, it can be helpful to ask these questions about your loved one with dementia. What would she have wanted before the dementia developed? What would she have done if she knew she was hurting other people? Would she want to take a medication if it might keep her from hearing or seeing scary things? Answering these questions can help you to think about what goals your loved one would have for controlling the behaviors. Often people are willing to accept the risk of antipsychotics if it means they would not be hurting anyone or would be more comfortable. As a surrogate decision maker, you need to work with the healthcare team to make a shared decision which reflects your loved one's previously stated goals and wishes. We hope that this talk gave you a better understanding of shared decision making and gave you some ideas of how to have discussions with your loved one's physician. Shared decision making is important because it can help you to make a decision which follows the goals that are important to your loved one. Shared decision making works best when you have told the healthcare team what is important to your loved one and when the healthcare team has told you what is going on and offers suggestions on the best way to proceed. Thank you for taking the time to view this mini lecture on shared decision making. We hope that it was informative and will improve your communication with the healthcare team.